This topic, imbalance and dizziness, is one of my passions. I dedicate about 50% of my research time to this very specific topic. So on talking with Dr. Evidente, he felt that it would be best to, to cover this for me. So we need to start by saying, okay, so why do we need to talk about imbalance? Well, really, the bottom line is that falls are common and lethal. 1 in 4 Americans age 65 or older fall each year. Every 11 seconds, an older adult is treated in the emergency room for a fall. And every 19 minutes, an older adult dies from a fall. I mean, I think that these are staggering numbers. And falls are the leading cause of fatal injury and the most common cause of non-fatal trauma-related hospital admissions among older adults. So as you can see, imbalance is a real problem, it's a major problem, and we need to be working more on it. The next question is, all right, so why do we need to talk about dizziness? And the summary is that dizziness is common, is expensive, and is truly problematic. Dizziness, including vertigo, affects about 15 to 20% of adults yearly in large population-based studies. And vestibular vertigo accounts for about a quarter of all the dizziness patients. And the prevalence is about 5%, in a single year. So this is very common, and the prevalence rises with age and is more common in females than it is in men. So then, okay, imbalance and dizziness are important. So is this a topic that should be part of a movement disorders talk? And the reason for doing this is that they are very common in many movement disorder patients. I have listed here some of the common diagnoses in movement disorders where a problem of imbalance and dizziness is common. Parkinson's disease, Parkinson's plus syndromes, including all of these that we have listed there, essential tremor plus, ataxia, dystonia, orthostatic tremor, which is one of the few diseases where imbalance is the main symptom that is listed here, and then normal pressure hydrocephalus. So yes, dizziness and imbalance are very common in movement disorders, and therefore we should all be talking about that. Let's start with Parkinson's disease, which is a common condition in everywhere in the United States and the world. About 1% of the population has Parkinson's disease. So to put some perspective, I live in Nebraska, a very big state with only 2 million people of population. So if it's 1%, it means that 20,000 Parkinson patients live in this state. And when I came here, I was the only fellowship trained movement disorder expert to take care of all of these people. So as you can see, it's very, very common. So in Arizona, it's gonna be a lot bigger the number of Parkinson's patients. And Parkinson's, it's a progressive illness, and you have some early symptoms like resting tremor and slowness of movement and stiffness. And then as the disease progresses, you can have balance issues and falls, postural instability, and gait disturbances. In Parkinson's disease, imbalance is common. Over the course of a year, falls occur in 54% of patients with Parkinson's disease, PD, and frequent falls occur in 20% of patients. So that's a ton of falls, right? That's a ton of falls. And And it can be, as we discussed, very dangerous for the patients. What are the risk factors for fallers? So fallers showed higher scores in scales that reveal the level of severity of Parkinson's disease, and that makes sense, right? The more severe the disease, the higher the likelihood of developing balance issues. The next one is cognitive impairment. So if patients develop dementia, then that increases the risk for imbalance. Depression, older age, previously reported falls, and freezing of gait. Freezing of gait is a common phenomenon in Parkinson's disease. It occurs in 10 to 20% of the patients. And the way it works is that patients are trying to move, but their feet are not moving. They're like, frozen. And that's why it's called freezing of gait. So the higher the severity of this freezing of gait, then of course, the higher the risk for imbalance and falling. Other risk factors include taking medications that can cause drowsiness, patients having something else outside of Parkinson's, like Parkinson's plus syndromes, and we'll talk about that a little bit. Also, patients having dystonia had a higher risk for falling. And dystonia just means that the patients are having excessive muscle contractions that can cause abnormal postures, or they can cause muscle tightness and pain. Common dystonias in patients with Parkinson's disease include dystonia in the feet, where toes are curling excessively, particularly while standing or walking, or foot turning dystonias, where the feet, one or two, usually one, tends to turn abnormally, to have an abnormal posture. And when patients have that, they have a higher risk for falling. And then lastly, dyskinesias, which is a side effect from medications, where the patients are having too much movement, wiggly movements and excessive movement. They're over. They're not off, they're not on, they're over. And then when you get that, that increases the risk for falling as well. Being in the off state is also important to consider. So if a patient is having, has not taken the medications, or the medication benefit has gone away, then, that is another important risk factor for patients with Parkinson's and falling. Okay, let's see here. So why the patients fall? Well, the freezing, the posture, general muscle weakness, that's an important one. If patients are not exercising and they're not staying active, then they start having muscle atrophy. And with that, generalized fatigue and generalized weakness. And that increases the risk for falling. Importantly, problems with blood pressure. So we will review in a second how low blood pressures can cause severe problems in patients with Parkinson's disease. And lastly, vision problems. If you have eye problems and vision problems, that can definitely increase the risk of falling. So let's talk a little bit about autonomic dysfunction in Parkinson's disease. There are basically two types of systems in the brain. One is the system that controls, most of the functions that people think about when they think about the brain. But the other is the autonomic nervous system, and that system controls, autonomous activities, the vital activities in the body. So, for example, that's the system that controls heart rate and blood pressure, and it controls your breathing, breathing frequency and breathing rate and depth of breathing. It also controls your bowel movements and your intestinal function, gastrointestinal function in general. It controls your urinary function, including the start of urination and the continuation of urination, and feeling of the bladder being full versus being empty. It also controls sexual function and sweating. So in patients with Parkinson's disease, the autonomic function is affected. And the way that presents is when the cardiovascular system is not working is as orthostatic hypotension. And then when the GI, gastrointestinal system is not working, then you have constipation and you can have incontinence. And then you can have sexual dysfunction and sweating dysfunction, which are all relatively common in patients with Parkinson's disease. Some people think that the brain has more neurons than every other body part, but in all reality, the number of neurons, the cells that control the brain system, the number of neurons located in the abdomen and chest is bigger than that we have in the brain. And that's my justification for being fat, because I'm thinking with my belly, right? That's the way it works. Anyways, beyond the bad joke, what is important is to recognize how huge is the impact of the nervous system in the control of the gastrointestinal and blood pressure and cardiovascular and respiratory systems. And then if that contribution is so big, it means also that when the nervous system is affected, like in Parkinson's disease, we are at risk of having those functions not working appropriately. Let's talk a little bit about what do we mean by orthostatic hypotension. The way this works is orthostatic means standing. It's just a funny name for standing. And hypotension just means that the blood pressure is low. And what tends to happen is, I'm going to show, this occurs in about 30 to 40% of patients with Parkinson's disease. I'm going to show a picture that does a much better job at it, at explaining it. But the kind of symptoms that you can have with orthostatic hypotension are listed here. So if you are lying down and then you get up and the blood is not reaching your brain, what kind of symptoms could you get? Well, you can get dizziness, you can get blurry vision, fatigue, weakness, fainting, which is the extreme, right? So if you don't get enough blood into the brain, then you're going to pass out, which is very problematic for many patients with this condition. So why is this happening? Well, here this picture shows a patient sitting, and you can see the blue shade of the patient is covering most of the body. And let's think that that is just blood, okay? But when the patient stands up, then all of that blood rushes down to the feet because of gravity. And when that happens, then the head starts having small blood volume. When that happens, then the brain and the arteries sense this issue and activate a reflex that produces the heart rate to start pumping faster, the heart to start pumping faster. And when that occurs, then we replenish our entire body with blood, and therefore we're getting enough blood into the brain and the blood pressure normalizes. So the issue with patients with orthostatic hypotension is that this reflex doesn't work. And when that reflex doesn't work, then the patients remain, when they are standing, they remain in a state where the brain is not receiving enough blood flow. And when that happens, you tend to have, you know, hold on. You tend to have these types of symptoms. And I have had patients with many other symptoms from this situation, including thinking and memory problems. I had a patient who loved riding horses, and what he was telling me is that he would be able to drive normally and not get lost, but if he was riding his horse, he noticed that he would get disoriented. So, you know, his doctor had told him that it was because he was having the beginnings of dementia, but we did the dementia testing and it was normal. And we just noticed that the issue was that of blood pressure. So if you have too low of a blood pressure, that can be a problem. It is important, though, for you to know that these patients with the orthostatic hypotension, they tend to have high blood pressure when they are lying down. So when you're lying down in bed or even while sitting, the blood pressure tends to be a little bit higher, sometimes very high when you're lying down. And that's a problem because when patients go, for example, to an emergency department and they get their blood pressure measured, people are gonna, you know, just find a very high blood pressure, and they're gonna think that the symptoms were due to elevated blood pressure, when in fact, the problem is that if you stand up and you measure the blood pressure while standing, then that pressure goes down dramatically, and that is actually the actual cause of the symptoms. So this is an important conundrum in this particular situation. What are the risk factors for orthostatic hypotension? Well, medications are the number one and probably two and three risk factor, and age. The older we get, the higher the risk for orthostatic hypotension. And then there are many medications that reduce blood pressure, and that can induce orthostatic hypotension. Diseases like Parkinson's disease and heart problems and neuropathy can induce that, as well as being exposed to heat, long bed rest, pregnancy, and use of alcohol are all risk factors for this problem. How do we diagnose orthostatic hypotension? Well, you can start at home by just measuring your blood pressure while lying down, and then after 5 minutes of being lying down in bed, you measure the blood pressure. Then you sit up and you wait for 5 minutes, and you measure the blood pressure again while sitting. And lastly, you stand up and you stay standing for 5 minutes, 3 to 5 minutes, and you measure the blood pressure and the heart rate one more time. And if the blood pressure drops when you are standing significantly, then we know that you have some degree of orthostatic hypotension. But the best way of diagnosing this condition is by having a full autonomic lab testing, which can provide a lot of important information about your autonomic system. And that includes the tilt table testing and beat-to-beat hemodynamics associated with the Valsalva maneuver. There are patients also who can get cardiac sympathetic imaging, and that can be very helpful on knowing what kind of orthostatic hypotension are we dealing with. So these are the tests that we tend to use commonly for patients with this condition. Well, what else could we do? How can we do to fix this problem of the low blood pressure? Well, one is actually to increase salt in our diet. As you know, we're always telling our patients to not overuse salt because it can increase the blood pressure. In this case, that's exactly what we're trying to achieve. Also, eating small meals can be helpful because if you eat a large meal, it increases your risk of dropping the blood pressure. We have to make sure that the patients are not having a vitamin deficiency. And in a study that we have done in Nebraska in collaboration with Harvard, we have found that the prevalence of any vitamin deficiency in patients with Parkinson's disease is about 30%. So they are very common and they need to be looked at. And then it is important to get plenty of fluids. And what I mean by that is at least 60 ounces of fluid every day. Now, that doesn't include things that make you urinate more or lose your water, like coffee or like beer, right? This is more like water and juices and things that replenish your water levels. And lastly, to avoid alcohol, and that can be very helpful in some patients as well. Another change that you could do to help with this blood pressure issue is to move right. And for that, it is important to exercise because regular cardiovascular and strengthening exercises may help reduce the symptoms of orthostatic hypotension. Also avoid bending at the waist. Is better to squat with your knees to recover if you can. Some patients are unable to do that. You can use waist-high compression stockings that can be helpful to reduce the low blood pressure problem. Making changes in posture slowly can be very helpful. And also to move your legs while standing. If you're just standing there and not moving, the muscles in the legs are not helping the blood that is accumulating in the legs to get out. But if you're moving your legs, then those muscles are also pumping. And then through that pumping, you can elevate your blood pressure back to normal. These are some counter maneuvers that can raise the orthostatic blood pressure. And you can see that basically many different movements and positions have been shown to be helpful on increasing that blood pressure. I wanted to mention this last part that is important. Since your blood pressure, if you have this condition, the blood pressure when you're standing is low, but the blood pressure when you're lying down is high, then at night, when you're going to sleep, it might make sense to raise the head of the bed, because by doing that, you reduce the amount of hypertension that you are having at that time. So you reduce the increased blood pressure that you get when you're lying down in bed. There are a number of medications that can be used for neurogenic orthostatic hypotension, and we commonly use fludrocortisone and midodrine and droxidopa, and many other medications have been used in the past, but these are the main ones to consider. And droxidopa has been shown to be beneficial and is FDA approved for neurogenic orthostatic hypotension, which is what tends to happen on patients with Parkinson's disease or Parkinson's plus syndromes. So going back to the more motor problems in Parkinson's, postural instability is definitely an important problem, is common, and it can lead to falls that can cause injury. So we need to keep that in mind. Some of you might know a lot about what, the Parkinson's plus syndromes versus not, and how all of that works. So I'm going to start by explaining how we go about diagnosing these conditions. On the very top, you have the 3 diagnostic criteria that are required to make a diagnosis of Parkinsonism. Parkinsonism means that you look like you have Parkinson's disease, but there are many reasons for Parkinson's disease, for Parkinsonism, I mean. So if you have tremor, rigidity, and slowness, that fulfills the criteria for Parkinsonism. Of those 3, the only one that is required to have is the slowness. So let's say that you have Parkinsonism. Then there are basically 2 options here to think about in terms of neurodegenerative conditions. One is idiopathic Parkinson's disease, or the regular Parkinson's disease, and the other is these Parkinson's plus syndromes. That, as you might guess, it means that you have Parkinson's plus something else on top of the typical symptoms that patients with Parkinson's have. So the bradykinesia can present in many ways. For example, in small handwriting, or decreased arm swing, or loss of facial expression, slowness of movement, etc. The rigidity is just stiffness, and the tremor is the resting tremor. But patients can also have loss of postural reflexes and gait freezing, as we discussed. All Parkinsonism patients share these features, but idiopathic Parkinson's disease is characterized by them. If you have stuff on top of these symptoms, then that's when we worry about the PD+. When you have additional features that differentiates idiopathic Parkinson's disease from the Parkinson's plus syndromes, the PD+. So the Parkinsonism classification then goes as either primary or secondary. In the primary, you have this Parkinson's disease and the atypical disorders, or PD+ syndromes. But then you also have these secondary Parkinsonisms, which are usually medication-induced or induced by strokes or by toxins or by trauma. And you could, take a medication that makes you look exactly like you have Parkinson's disease, but in fact is not. In fact, all you're having is a medication side effect. The 2 most common medications that can cause that are anti-nausea medications and also antipsychotics. So they tend to be drugs that block the dopamine, which is the substance in the brain that patients with Parkinson's don't have. All right, so here, we go back to this tree of the classification of Parkinsonian disorders. So if you are primary, then you have the 2 options in Parkinson's disease versus the PD+. And the PD+, the common ones include progressive supranuclear palsy, corticobasal degeneration, multiple systems atrophy, and some people include dementia with Lewy bodies in there. So the way to see if you have a PD+ starts by a comprehensive history and a thorough physical examination, usually performed by a movement disorder expert. And what we're looking for is the presence of ataxia, which means clumsiness, abnormal reflexes, autonomic failure, abnormal eye movements, and other examination abnormalities. And here we have a complex table, so it's not for all of us to really learn each of these, the details of each of these diseases, but just so you get a feel for how these PD+ syndromes work. So for example, if you have these typical signs and symptoms of Parkinson's disease, plus ataxia, meaning severe clumsiness, then the most likely explanation is that you don't have Parkinson's disease. What you have is multiple systems atrophy of the cerebellar subtype. And this condition has many other features, like, for example, a much faster progression and less response to treatment. If you have, for example, severe dysautonomia, meaning that your autonomic nervous system is not working well, then you start thinking about multiple systems atrophy of the autonomic subtype. And, you know, another old name for that disease was Scheidegger syndrome. If you have abnormal extraocular movements, abnormal movements of your eyes, then the most likely explanation would be progressive supranuclear palsy. And this one comes with a number of other features, including early falls, meaning that the patients start falling within 1 or 2 years of the development of their symptoms. So that's how PD plus syndromes work. You have a patient that looks like Parkinson's disease, but it has other features that predominate. And as you can see on this table, the prognosis for these conditions is worse. They tend to respond less to treatment, and the disease tends to progress a little bit faster. Well, I'm going to now be talking about a topic that is near and dear to my heart, which is orthostatic tremor. And why did I get so enamored by this disease, the orthostatic tremor? As you can tell, orthostatic, we already discussed, it means standing. And tremor is just shaking. So it's a shaking while standing. Well, the story was this. I was in St. Louis and in training, and I saw this gentleman who owned a shoe factory. And he was telling me that he was running, you know, his shoes like crazy, that he was destroying the shoes basically because he could not stand up. So when he had to do things, he had to be walking continuously. And I asked him, you know, why? And he said, well, it's just because I just feel so uncomfortable. And I found that to be fascinating. At the beginning, I was thinking, well, is this a type of restless leg syndrome, or what's going on? And he had significant impairment of his quality of life. You know, at the time he was 80. So, you know, he was just walking constantly. And then I started to learn that this disease, the orthostatic tremor, was very difficult to diagnose and terribly under-recognized and terribly understudied. When I went to search for data, I only found about 100 papers. So I couldn't even answer the questions that my patient was having. And there were no real treatments for this condition. And what he told me is, you know what? I keep on walking so I don't fall. So that's an interesting part of this condition. Is really fascinating. When they are sitting down, they feel completely normal. But as soon as they stand up, they get some shaking in the legs and in the rest of the body. And then they start feeling unstable. They start feeling like they are about to fall down. And then if they start walking, that feeling goes away. Now, imagine how the visit with the doctor would go, or with anybody that you know. It's like, oh yeah, I'm having a terrible problem with balance. Oh, tell me about it. Well, yes, if I'm sitting, I feel normal. If I stand up, I am about to fall down. I have a terrible imbalance while standing. But if I start walking fast, then I don't have any imbalance and I don't fall. So imagine how the physician or anybody else on the other side is going to think. If they have never heard of this condition, orthostatic tremor, they could think that the patient is just crazy or is anxious, or, you know, that there's definitely nothing wrong with the brain, because if by walking the sensation goes away, it doesn't make any sense that this would be an imbalance disease. So orthostatic tremor is a movement disorder characterized by a tremor and a sensation of impending fall upon standing that improve by walking, by holding onto something, or by sitting back down. And it is the disease that produces the highest frequency of tremor in the legs. The shaking is so fast that you cannot really see it with the naked eye, because it goes back and forth about 15 times per second. Now, it is important to recognize that orthostatic tremor not only is a disease within itself, but it also presents or accompanies many other neurological conditions. And I have listed here some, but it includes conditions like Parkinson's disease, like restless leg syndrome, neuropathies, ataxia, cerebellar degeneration, peripheral neuropathy. So there are many conditions, dystonia, that where orthostatic tremor can be associated, an associated presentation on top of the regular disease. We did an OT review of all cases ever published in the literature until 2015, trying to look for some answers. And I have some, just general information to share here with you. OT is a disease of the Middle Ages. Mean age of onset is 56, but the youngest age is 7, and the oldest age was 87. So basically, it can happen at any age. And the mean duration of symptoms before getting a diagnosis is about 10 years. So patients can suffer for 10 years before they can get a diagnosis, which is horrible. And this is a disease that is more common in females than in males. About 2/3 of patients are female. How often do patients fall? It is rare. Falls are rare with this condition, but they feel extremely unsteady. I believe that disease progression is seen in this condition. I have many patients who tell me that. What other tremors can be seen in orthostatic tremor? About 2/3 of patients have hand tremors, particularly while standing. So let's talk about this for a second, so that we see why this condition is so interesting. Since patients rarely fall, are patients truly unsteady, or do they just feel unsteady? If they are unsteady, then how come the unsteadiness can cause the tremor? And is this the same tremor as when someone is scared? And other questions, if they just feel unsteady, then what's the localization in the brain for the sensation of unsteadiness? Is this a phobia of standing? How can this disease help us prevent falls in other types of diseases? So we have a number of studies that we have completed over the years trying to answer these questions. And these are all of the future, a partial list of our future projects as well on this condition. I'm going to dedicate the last part of my presentation on how can we help patients with imbalance. There's definitely a lot of things that we could do to help our patients with imbalance. The first thing, this is coming from the PD UK, the Parkinson's Disease UK Association, and they provide 7 steps to better walking. The first one is to get into a rhythm when you are walking. So, choose a particular song or listen to music, and that can be very helpful. Basically, move to the beat. Focus on taking longer strides and swinging your arms. That can be helpful as well. Shift your weight, move your weight from one foot to the other as you are walking. If there is some freezing of gait, you may be able to restart moving by rocking gently from side to side. Ask a friend to help. When you are having walking difficulties, just make sure that you can ask people around or a friend or a family member to assist you, so that ensure that you don't fall, because falls, as we discussed, can be extremely dangerous. Avoid distractions. There are a ton of studies showing that if patients with imbalance or instability, if they are walking without doing anything else, they do so much better than if they're walking and doing something else. And it could be small distractions. For example, we have done studies where patients who are walking forward, we ask them to turn the head to the right and then turn the head to the left. And just by doing that, their postural instability can worsen dramatically. So avoid distractions. And we live in such, an environment that enhances our distractibility, in particular with the cell phones. So if you're walking and this thing is going, well, stop and then pick up the phone and talk, and then you move. Slow down your turns. When you're turning, is one of the highest risk times for falling. So it is important that you catch your bearings, that you catch your breath, slow down on turns. And also, when you have to walk backwards, be very careful. People don't think that they walk backwards, but we do that all the time. For example, if you're approaching a door and you have to open the door and pull it towards you, well, at that moment, you're going to be walking backwards or stepping backwards. That's a high risk time. Also, when you're opening the refrigerator or opening the oven at home, there are many times we don't think about it when we actually have to step backwards. And when you do that, that's a high risk time for falling. So you want to make sure that if you're going to walk backwards or step backward, that your environment is appropriate, that you are going to be able to hold on to something in case that you fall, and to think through it before you start performing the activity. What else can you do to reduce the risk of falling? Well, though it may be tempting, try not to restrict all of your activities. Some people tell me, well, I cannot exercise because I cannot walk. Well, that is not true. We have athletes who are paraplegic and on a wheelchair, right? So you can exercise, you can increase the muscle strength of all of your muscles through activities that you can perform while sitting. I tell my patients that if they're watching TV, all I ask them to do is to grab a bag from Walmart and put inside, 2 pounds of sugar. And then as they're watching TV, they start lifting that bag. And you will notice that you're going to think that this is a silly exercise. By the number 20 repeat, you're starting to feel it. You have to change it to the other hand because you get really tired. And you can do the same with your legs, put some weights in the legs and move them while you're seated. You can do a lot of exercise without, even if you are unable to walk. It is important to try to stay as active as possible and exercise regularly. Put it in your calendar so that you maintain your mobility and you prevent your falls. Consider always chatting with an occupational therapist or a physical therapist so that they can help you continue to enjoy the activities that you do. The more fit and active you are, the better your body will be able to respond to the demands that we place on it, and therefore to avoid injury when you're falling, or even avoid falls. You can use equipment and walking aids, and the occupational therapist can help you a lot with that, as well as the physical therapist. And they can be very, very useful. In fact, I've always said that everybody should have a physical therapist and an occupational therapist in their life, because they can teach you how to do things better, for sure. Be mindful of the footwear. I don't know how many times patients come to see me and for imbalance and walking difficulties, and when I see them, they're wearing footwear that is not conducive to safety. It can be both the rigid, say, high heels type of footwear. That's not good. And also the flip-flops and Crocs style of footwear, which are actually too loose and can interfere with your walking and make you trip and fall. So be mindful of the footwear, talk about it with your physical therapist, because they can give you some very good ideas on how to improve that and decrease your risk of falling. A lot of patients ask me, well, can exercise really help, doctor? And the answer is a definite, rotund yes. Exercise can help, and there are hundreds of studies on these. Some of the studies, but have shown that, for example, dancing tango and dancing salsa and working on the Wii and going to the gym and just simply walking and doing bike riding, all of those things help. So it doesn't seem that it's a specific type of exercise that is needed, like yoga, tai chi, everything helps. It's not the type of exercise, is basically, do you exercise versus not? That's what makes the big difference. On this study that evaluated the effects of exercise for people with Parkinson's disease, they reviewed 25 randomized controlled trials to see if exercise was helpful. And the results basically show very positive effects of exercise on enhancing balance and gait performance and reducing the fall rate. So, there is tons of data. The problem is, can we do it? Lastly, in terms of fall prevention, I think it's important that we are mindful of our environment, particularly at home. And oftentimes it makes sense to ask occupational therapists to do a special type of evaluation at home that is called home safety eval. And the home safety evals, what they do is they go there and they help you navigate the entire home and see what are the things that we need to move and the things that we need to change to increase your safety while at home. Some things that are important to consider is what kind of floorings do you have? Are rugs present or not? Like smaller rugs or large rugs, long rugs, thick rugs, thick carpeting versus thin carpeting. What's the kind of flooring that is best for you? How is your bathroom? Do you have standing poles that can help you get up, or in the shower, is this a walk-in shower? Do you have handles to help you stay there? And how do you come in? How do you come out of the shower or the bathtub? All of those things can be assessed by an occupational therapy. Lighting. What is your, how bright is the house? That can make a difference on falling. Kitchen and bathroom are the two major areas for falls. So, those two have to be looked at very, very carefully. How about stairs? If you have stairs, how does that work? And how often do you have to take them? And, make considerations for chair, stair lifts and things like that. And then the entrances and the doorways are also important to consider. All of these inside the house, and then outside the house, you have many other options too. Particularly here in Nebraska, we get snow and, freezing temperatures and ice, and all of those things you have to pay attention to as you're trying to prevent falling. So make sure that you talk to your physicians about all of these things that we have been talking about. And in particular, if you're falling, I would really recommend that you enhance your exercise, that you visit with a physical therapist that can help you with devices. Some patients, just pick up a stick and start walking with a cane without knowing that there are many different types of canes, and depending on your neurological condition, it might be better to use the one type of cane versus another. The physical therapists are experts on that and can help you figure out which ones do you need. Some patients believe that by using a walker, they're going to be safer, but then when you're inside your home and you're in the bathroom, maybe using the walker is increasing your risk of falling rather than decreasing the risk of falling. The occupational therapists and the physical therapists can help you figure that out. Some of these changes that are needed in the houses can be covered by some insurances. So that is also important to realize. Some people think that the changes that are going to be made might be too expensive for them. And some of these changes actually might be covered by insurance. And some of the changes can be extremely inexpensive and make a huge difference on your quality of life. Remember, at the end, the goal is to keep you at home safely for as long as we can, so that you don't have to be institutionalized. If you're falling all the time, then of course it reaches a point when you're not safe to live at home anymore, and then institutionalization become a consideration. So we have to do whatever it takes to prevent reaching that stage. What do we do after we fall? All right, we're not able to prevent the falls. What do we do after we fall down? The bottom line is that it's important to work with a physical therapist to prepare a system in case that a fall occurs. The first step is don't panic. Some people, when they fall down, they think that they have to get up immediately. It's like, what's the rush? You're now in the floor. Don't move. Don't panic. Don't go fast. Take time to get up. Take time to get help. If you're a caregiver, help the patient scoot to a solid piece of furniture so that they can use that as they are getting up. If you have a transfer belt that can provide some grip for the aiding person, you could put that and use it. Before you start rising from the floor, make sure that everybody around, including the person who has fallen, make sure that everybody is aware of the plan. Meaning, okay, at the count of 3, you're going to move the right foot forward, then we're gonna lift you forward using the belt, and you're gonna grab to this chair and pull and try, So basically, make sure that the plan around fixing the fall is clear on everybody's mind. And if you determine that it's just unsafe for you to do this alone as a caregiver with the person who has fallen, then just call for help, right? It is very important to avoid future injury and future damage. If the patient is having any neurological symptoms after a fall, then it's better to call 911. So anything that is not completely normal, it's better to call 911. Neck pain or difficulty moving the head or the neck or the feet or the legs, all of those things mean that it's better to call for help and to make sure that the patient is safe before getting up. And with that, I will end, and I sincerely appreciate all of your kindness in inviting me. This has been a wonderful experience.